All right, perfect. So we might begin now. It's just gone 6 o'clock. So I just wanted to welcome everyone here for tonight's webinar, which is an update for COVID-19. This is our 8th webinar now, which is pretty exciting. I can't believe we've been doing this for so many weeks. And this week, 0 cases, which is pretty impressive. So first of all, I'd just like to acknowledge the land in which we're meeting here tonight. For us here at the AMA offices, we're meeting on the Kaurna land, and we wish to acknowledge the land wherever you are tonight and logging in for the webinar. And we wish to thank those elders who have cared for the lands in which we are here today and thank them for everything they've done for us. So thank you so much to the Kaurna people. I just wanted to thank the Adelaide PHN again for hosting the webinar, and just to give a bit of an introduction of who's here around the room so we can discuss all things COVID tonight. So we've got Dr. Chris Moy, AMA SA President. We've got Crystal Myers here from Adelaide PHN. We've got Louise Flood here, who's the Director of the CDCB. Dr. Tom Flood, who is the Clinical Service Director at SA Pathology. And we've got Dr. Jenny Gould here as well from the GP assessment team for COVID-19, and myself, Emily Kirkpatrick, Deputy Chair of the RACGP SA&NT faculty and GP liaison at SA Health. So what we'll do is we'll start with Louise first of all to give us a bit of an update of where things are at. And obviously, Louise, you must be pleased with the good news of 0 cases.
Yes, it's good. It's good. So I am just giving a bit of an epidemiology update, just our cases internationally, nationally and in South Australia. So far, this is just the report from that came out yesterday evening. So over 3 million confirmed cases, which is huge, with over 211,000 deaths. And most of those deaths have been in a few countries, so USA with 24%, Italy with 13%, Spain with 12%, France with 12%. And the case fatality rate is the same as it was last time I reported it, 6.9%. And as I've said multiple times, that rate does depend on who gets tested, and if you're testing a wide proportion of people, as in if you're testing people with mild symptoms versus just testing people who go to hospital. Looking at the map for the last 7 days, still large numbers are in the US and parts of Europe. Australia is there, it features there, but it's in the middle colour there. And we are getting cases in all continents, and as I said, does depend on where the testing is done. How much testing is done will affect how many cases are reported. This is the scale showing the number of cases that have occurred on a scale against the day since reaching 100. And you can see Australia is doing fantastically well there, with our curve getting extremely flat. So I think you would say we have reached our aim of flattening the curve there. Well, I'm not sure which curve they were referring to, but to me that's a flattening that curve there. And you can see Republic of Korea is also doing very well there, with theirs being very flat. But you can see those, well, USA right up there on them by themselves, and then also the significant increase that's been occurring in Singapore and Japan. They had been doing well, and then that's picked up there. And then just looking at the epidemic curve, it continues to be large numbers in the Americas and in Europe, but it's maybe a little flatter than it had been. Looking at the number of confirmed cases in Australia, we're up to, this is as of yesterday late afternoon, 6,731 cases. With the largest numbers of cases being in New South Wales with over 3,000 cases, and Queensland over 1,000 cases, and Victoria on just over 1,300 cases. Still a very large proportion of cases are overseas acquired. If you can, around 2/3 or so are overseas or acquired across Australia. And there have been areas that have had larger numbers of locally acquired cases, with Tasmania sort of sticking out there as having a larger proportion of locally acquired cases compared with overseas acquired cases, and that would be related to the hospital outbreak they've had in the north of Tasmania. It's also quite encouraging looking at the increase over the past week, but those numbers have decreased a lot compared with what we had several weeks ago. And there's our curve that has definitely a big decrease in the number of cases that we've had compared with what we were having in mid-March. And there you can see the cases against the various events that occurred, such as the travel ban, where there was we had the peak there, but still very low numbers there. But it does, with that 2-week incubation period, that will any changes that come into effect now do have that bit of delay in seeing whether that is going to make an impact on the cases. So looking at the cases in South Australia, you can see no cases reported yesterday, and we've had it's around a week with no new lab confirmed cases. And so that's what our epidemic curve looks at as of from yesterday's report. And you can see we've last had a case was their date of onset was on the 18th of April, so it's quite a little while ago, and then our last little cluster was even further away than that, which is very encouraging. And just looking at the age and sex, still very small numbers have occurred in children, and that does reflect what people are finding globally. But apart from that, except in the 40 to 49-year-old age group, fairly even sex distribution. And just to let you know, it's still a notifiable condition, and you can do it, notify it online. And that was all I had.
Thank you, Louise. I had a couple of questions for you. Is that all right? Just in terms of, I was hearing around the 7 cases where there's been no identifiable link, and there were discussions around sort of testing that can be done, or extra testing that can be done on those particular swabs. I don't know if you're able to tell us a little bit about what that means of this. Is it genetic type? Is it looking at a finer detail at the swabs themselves, or how does that all work? Because I know we've had a few questions come through about that.
So when we have those cases, we're always trying to link cases and find out where people might have got that from, to see whether we've got chains of transmission that we're not aware of. And so with those cases, there's a few ones where we've asked for serology to see if we can link people who had an earlier illness and have been swabbed and have come back negative with their PCR, but they had an illness several weeks earlier, just to see whether they have in fact, we can link that person to another chain of transmission, and so those swabs have been the blood for serology has been taken and has been sent into state, and we're waiting for those results. But we're also, the other thing is doing the genetic testing to see whether we can link some of these others together with. Again, trying to link our cases together and see if they're joined, and so that some of our locally transmitted cases can be assigned to a particular cluster, and so we can get that epi-link. Again, with the genetic testing, we're not sure how reliable that will be from the point of view of whether it will actually help us link those or not. Whether it's going to, just sort of say they acquired it in Europe versus anything like that, because it may not be that useful, but you might have more to say on that, Tom.
So people will be of interest that in about 3 weeks we'll have the ability to do whole genome sequencing on all of our cases in South Australia, so it'll be quite interesting to see whether there are any common patterns
Right, and will that be on the blood? Will that be on a
No,
blood
that'll
test
be
or on the swab still?
that'll be on the material we
Right.
have in the positives.
I was just going to say, I had this chat with you earlier, Tom, about this issue, because in Iceland, they've actually been doing all the genotype testing, and they've actually looked at where they've come, like from whether and there has been this, they've helped in their contact tracing with respect to whether they come from Italy or whatever. And I think speaking to some other people, the question is whether there is actually some association. I mean, I think it's way too early, but is there some association with severity as well? Speaking to some of the heavy duty virologists in this area, this will be very interesting. But I think Tom, speaking Tom, I think that's a really good way to go at the moment, and see whether we can do a bit of matching about how they went clinically as well.
Yeah, that's right. So with only around the 400 cases, we'll easily be able to do whole genome sequencing on all cases. So that'll be interesting.
That does sound very impressive. Actually, we just had a question come through as well around overseas travellers and whether there's any role for undertaking serology or antibody tests in people who came from overseas and perhaps were unwell but didn't get tested for COVID. Is there any role at all for that, or any research that you know of happening in this space?
So I'm well aware that we are going to move towards some serological testing, and once again, SA Pathology will be able to offer a reliable serological test shortly, and then I guess it'll be a question about which groups of patients should and shouldn't be tested. Those, perhaps with an overseas travel history might report a compatible illness from overseas, and then there may be some sentinel testing I know that's been talked about as well.
I suppose, though, it still goes back to the why would you test them when we're not sure, if someone's had it, that we don't necessarily know that means they can't get it again. So,
and I think we do have to be quite careful, because it's the prior probability of your test. We all know that some tests have false positives, and if the incidence in the community is very, very low, probably way below potentially what could be false positives, in fact, we could cause ourselves some grief. So I think it'll need to be done in a very thoughtful way. Wholesale serological screening in South Australia would probably cause us far more difficulty than not doing it at this time.
And are we currently undertaking any IgM, IgG patterns of serological testing at all at the moment here in South Australia?
No, that'll come on with the serological. That'll be the basis of the serological testing in a few weeks.
Perfect. Thanks, Tom, for that. We might hand over to you to give us a bit of an update of what's been happening. So I put out an announcement as well about SA Pathology and domiciliary testing, and I presume you're going to talk about that as well, Tom, and give us a bit of an update. We are constantly putting out feedback from SA Pathology around what you're up to, because you are constantly innovating and thinking about new ways to deliver tests. And I put an update today around testing changes for immunological testing, and that was in regards to anti-CCP changes, and also to, I think it was to TSH receptor antibody testing as well, that has changed. So just to let you all know that I have put that out in the update today. So I'll hand over now to Dr. Tom Dodd, who'll give us a bit of an update there.
So as you all know, there's been this so-called blitz of testing over the last fortnight for any symptomatic patients, and the response has been very, very good. As of this morning, we had tested during the last fortnight just over 18,000 patients, which is very impressive. And you can see the bar graph here with the numbers of patients tested each day. It sort of follows this pattern during the week, and then slightly smaller numbers over the weekend. But nonetheless, if you remember that the baseline number of respiratory screens done sort of typically is around 150, we've been tipping up near that 2,000 mark on a number of occasions, and even as this has tailed off a little bit, still 1,400 or so yesterday. So it's been very good response, and my understanding is we're just going to continue on screening people who are symptomatic beyond this so-called blitz period, so it's going to be sort of normal practice. And I think it's giving us a very good sample. Total number of patients tested to date is around 54,000, so 3% of the population, or 1 in 33 South Australians tested, which puts us still very much at the most tested group in Australia and internationally. So the other points I just wanted to raise this afternoon or this evening was that We now have a very expanded domiciliary service, which is going to be widely available. We no longer require CDCB approval, but thank you, Louise, for helping us with that. So from here on in, general practitioners will be able to arrange to have domiciliary visits to your patients. There's been some communication go out today about how to do that. It's faxing through a request form, and then we'll contact your patient. It'll be widely available across the metropolitan area. We're looking to do some expanded DOM service on the Fleurieu Peninsula, and then also based out of each of our regional laboratories as well. So we've got significant capacity there. We're able to go and see patients who can't come to clinic or drive-throughs. We have the capacity and capability, if it were required, to go into nursing homes and swab large numbers of patients if that becomes necessary. Hopefully we never face that, but we nonetheless have that capacity. The SMS of negative results has now been in place for a little while now, and that's going very well. We've sent out several thousand negative results already. The only thing we've become aware of, and it's actually nothing to do with SA pathology or our personified care SMS system, is that it would appear that there has been some bogus apps that one or two people have had the misfortune of downloading that have been sending out, apparently, unbelievably, positive results to patients, which is an evil thing.
We had a call about this yesterday.
Yes.
A poor patient in the community had this happen to them, and I can verify that this is a scam, but it does exist, and it's not through those current apps. So please be reassured.
That's right. So we only send negative results to patients by SMS. So if there was a positive result coming through, it's clearly there's a scam about it or something quite wrong about that. We only send through negative results, and there's a human step checking that, so we would never send a positive result. And there's a slight time lag between the time that we send out the SMSs, so that we've got an opportunity for clinicians to become aware of a positive result and then contact the patient. So we would never send out any positive results like that. And the last thing just to mention is we're really now in the trialling phase, hopefully a broad rollout, the opportunity to send general pathology request forms via email for clinicians who are working outside of your normal practices, or if you're seeing patients by a teleconsultation.
Thanks, Tom, for that. Do you have any idea about how many SMSs you would have been sending out? Thousands of SMSs.
It's now well into the thousands.
Yes, yeah. And really that is reliant on the patient putting on their mobile phone number, or the GP who's already putting the patient's mobile phone number on that form and then clicking the link. Is that right?
Yeah, that's right. It's a two-step process. So there's a bit of security built into it. The patient needs to first register with Personify, and once that happens, then we send them a link. And once they've done that, then the negative SMS result comes through. But it's pretty straightforward.
And we've had a question come in about IgA responses. Would that be more important in terms of testing for COVID?
Yeah, well, that's an interesting question, isn't it? Because it's a mucosal infection. So I guess that'll be quite interesting to see once that comes through. Although I think most of the testing will be IgM. But yep, that'll be fascinating to see how that pans out.
I thought the Interstate Lab is doing IgA,
they may well be. They may well be, Louise. Yeah.
That is very interesting, isn't it? I guess this is just a constantly evolving space. We're talking about full genome sequencing as well. So everything's just progressing at a rapid speed. I'm going to hand over now to Dr. Jenny Gould, who's going to talk a little bit about the community COVID pathways. And then I thought it'd be really useful to have a bit of a chat around what we're doing for some of our international arrivals who are in quarantine, and that GP process, which has been amazingly offered through the South Australian Indian Medical Association. So I thought I'd give a bit of an update of where we're at with those passengers as well, and the care needs and the process then for coming out of quarantine. So Jenny's going to give us a bit of an update of community COVID pathways.
Hello and good evening, everyone. Thanks, Emily. So I think we've covered this before, but I thought I'd just do a quick flip through the community pathways. So the MRU, or the Metropolitan Referral Unit, are involved in these, and this is a group of senior capable nurses. And then there's the GP assessment team, which has been put together through GenWise, or 24/7 Med Care. So that's really the two components of the pathway. I've split the pathway into two bits, but just overall, this shows that once the person has tested positive and CDCB has notified them, then they're handed on to MRU, who then forward the information to the GP assessment team through GenWise, and then they're allocated a GP who's part of our core team, and they contact the patient and make an assessment. Now that'll be, physically and mentally, and really they're determining the path forward at that time for the patient as to whether they're safe to isolate at home, whether they need some acute care with a hospital visit or admission, and whether they need an alternative pathway such as different accommodation outside of the home. So then that assessment is sent back to the MRU and also to the usual GP. So the usual GP is kept notified of this whole process as we move through. So the MRU then actions the plan, and that can be up to twice a day phone calls, checking in on the patient, see how they're doing. Now, if they're concerned at any point in time, they will refer back to the GP assessment team, and that patient will be re-evaluated and an appropriate management plan made at that time. But if all goes smoothly and that patient continues to get better, and then them reaching the criteria for release of isolation, then they're referred back to the GP assessment team for clearance or release from isolation, and that's done according to the guidelines, and then patients are given a clearance certificate. And the GP is also, obviously, the usual GP is copied in on all that information as well, so that they know what's happening to their patient. I think thinking about moving forward and what are the lessons learned and planning for for what might be. I think with this process, the thing that has been overwhelming is that it went from 0 to about 110% in about a few days, really, and it's been an evolving process since. And I think that's a credit to everybody who's been involved to really pull that together. And my journey with this began with a call on a Monday night. I think it was the 23rd of March, asking from GP partners whether I could make some calls the next day. And then from there, GenWise said, would I come in and talk about what I'd done? And then the lovely Danny Byrne sort of put me forward, and I haven't really stopped since. But so I think with this, we've got continually changing processes, which is appropriate as we fine-tune things moving forward, and the guidelines, which are regularly updated as we know more and more about COVID. So we need a core group of skilled doctors and GPs managing these patients, because they can remain up to date, and I think this helps patients with their understanding, provides continuity of care, and ensures that the most up-to-date information is given, and that patients are more likely to be compliant with the guidelines. And I think mental health care is something that's become increasingly apparent to me, and the literature would also support that this is probably one of the biggest burdens moving forward with COVID. And I think GPs are ideally placed to manage mental health. We do that usually every day with mental health care plans and as such. And I think, that's probably one of the areas that I think if things are to escalate again, that needs some resourcing, because I think that's the biggest area where there's gaps at the moment. We get great feedback from the patients, but from their interactions with the MRU and the GPAT team. So I think that's evidence that it's well received. I think we've got a core group of GPs now currently trained with this process and completely across the most up-to-date guidelines. So should we need to escalate, at the moment we're really not having a lot to do, we are ready to go. So I think that's a big advantage. There's been no adverse outcomes. We started working through that list today, Emily, and really there has been no negative outcomes from this process. And I think the strength of this is about the relationships between all of the teams involved, and I think involving the usual GP in the process as about what's happening, because they are going to manage this patient long term, and also with the comorbidities that or their existing healthcare problems, even when the patient is COVID positive. So I think the teams really, the important thing is about the clear, consistent and up-to-date advice, especially around the release from isolation, where there's been lots of confusion that's led to a lot of distress in the community. And I think now that we've got this process in place that simplifies that and is going to minimise that. This just shows our numbers that have come through the GP assessment team, and I think the one to notice is that we've managed 150 from the beginning of their journey to the end now, when they've been released from isolation, and some of them I've still had ongoing contact with after. But and I think that's the best way when you involve through that whole process. But obviously that process wasn't established absolutely when we began. So I would just like to finish with a thank you to everyone who's been involved, because it's been enormously challenging times, exciting, stressful, but I have to say, I think without everybody pulling together, we would have never got to where we are. And I personally would like to thank everybody for the support they've given me. And for those people who know me, I like to exercise my creative brain by being a florist daughter, by making bunches of flowers. So I'm sending everyone virtual flowers because I can't send you all real flowers. Thank you.
Thanks, Jenny, so much for that update. I think that's really important for everyone to understand what the role of the GP assessment team is. And certainly it is very much a collaborative process, because it really is, this whole process and contact tracing is very important. That's the essential component, really, is the role of CDCB in this. And so to then be able to then work simultaneously with CDCB and be able to then assess these patients, their safety, they have the mental health assessment, all of those things to make sure they're okay in their home. And I'll emphasise again, which we said last week, around, thinking about isolating that positive patient as well out of the house as well, so they're not with others, so we don't get these 6 weeks of people being consistently in isolation of the contacts. And I just want to say that you've done such an amazing job, Jenny, and the fact that you've had your mobile available to so many GPs and have called you up for advice and been very helpful and constantly, there for the patients as well and providing advice. And I think I just wanted to emphasise this around the post-traumatic stress pictures that are emerging in these patients who have been positive with COVID and then have recovered. And the stigma that is associated with that has been huge. And I don't think we've quite got there. We're working with our comms team at SA Health to try and get some messaging out about this, because it is a really difficult time to, once you've been cleared, to know that you are okay to go and buy your essentials from the shops, to follow the normal social distancing measures that the government puts in place. So we're looking at how we can improve that. But please, if you are the GP of that patient who has had a positive COVID result and they've been cleared by the GP assessment team or through the LHN, or CDCB, it is really important that you provide reassurance and support that they know that they are safe to go out. And I think this comes back as well, and I was going to bring this up with you as well, Louise, around the changes again now to the CDNA song in terms of the swabbing at the end of coming out of clearance, that now there's been more categories put into that higher risk group. And I've heard of the anxieties in the nursing home sector as well around this, and the residential aged care facilities, that now they've been included in that group for the extra swab. So was that something, Louise, that has been sort of, obviously it's come from a national level, but is that just to provide extra clarity or reassurance, or do you know what the basis was for expanding the song to include those higher risk groups?
It's really about when you're doing a clinical clearance, there is always that slight risk that, well, firstly, the patient mightn't be telling you. They might have some symptoms that they're not being honest about. So you do still, there is always that slight possibility that they're not truly over that illness. And so I think if you do, so that's why when people are going into those higher risk settings, we just need that higher level of assurance that they really are cleared. And so that's why that classification, it's got both a clinical and a lab requirement, so that it's we can just be really sure that we're not having people going into those high-risk settings. So particular ones, you know, it's basically healthcare, aged care, Aboriginal communities, prisons, that sort of place that, you know, if we had a case that was you know, that person went there and then they were still infectious and they could potentially spread that to very vulnerable groups, and we could get outbreaks in those areas that we really, really don't want. So that's why it's just starting to be extra cautious, so that to be really sure those people are cleared.
Yeah, and I guess that is really important, isn't it? Because we don't know quite if people are telling us the truth as well with their symptoms. And Jenny, I think you're a bit of a detective, because you tend to find these things out from patients and done a great job of clearing them appropriately. And the other thing as well that's come through on the questions here is around requirements when coming in from interstate. So we've had a few discussions around that in terms of what are the requirements for them to isolate when they've arrived from interstate. And one example being an interstate traveller has come into the state, has then gone to seek routine medical care. Now, I mean, we offer telehealth and options for that, but it is a little bit confusing. I don't know whether if anyone wants to make any comments at all about the routine, you know, the travellers coming in. This is the non-essential workers. So travellers coming back into SA, whether they can access medical care or not.
Well, I mean, they would be required to do their 14 days of quarantine, which means they can access medical care, but, you know, telehealth in the first instance, and I guess we've got domiciliary and we've got hospital assessment if it needs to go beyond that. But the first port of call would be telehealth, as they're supposed to be at home or wherever it is that they're quarantining for those 14 days. Certainly with the women who are coming from across the border to come down to birth, we are getting them to come down, you know, with enough time to do the 2 weeks in quarantine, with still, you know, a buffer in case they were to go into labour before their planned caesarean or whatever. Yeah, so yes, telehealth I think is the way forward in this first instance.
And what are your thoughts, Louise, on this? I mean, this is something you've obviously been very involved in, is all the policies and directions.
Yeah, so I think, you have to think about what the whole point of those border restrictions, and it really is about limiting the spread of this disease and really keeping South Australia safe. And we do know, as Tom has pointed out, we've got really good rates of testing here. We don't think there's undetected disease happening. But I mean, if there is, it's at very, very low levels. And so that's what the aim of it all is. And so that's any directions that we give regarding it need to be going towards that aim. So it is about minimising. So if anyone's coming in here for non-essential reasons, that they should be doing that quarantine. And as Jenny said, yeah, telehealth where you possibly can. Urgent care obviously still should be had. And yeah, but most things should be able to wait for 2 weeks. Or if you can't have it in a telehealth sort of method, a lot of things can wait. But obviously, if it's an urgent care, they still needs to be had.
Yes, and just in, this is in terms of who tells them that. So really, when they cross the border, it's SAPOL who are providing that information around the direction, and they are given a piece of paper which does explain the direction as well, and their requirements to quarantine as well. So that's at the airport if they come by airplane, or if they're crossing the border, they're given advice by SAPOL around that. And it is working through that process and making sure that it is a clear message coming through, and they are going off the direction. So it's just making sure that we do provide additional extra advice, particularly if they're coming in for palliative care reasons as well, making sure that they're aware of the impact of them attending the home if they're going to be there when care is being provided, and that may potentially result in the care being delayed or changed while they're in the room with the patient. So we're just trying to communicate that all out and get some clear policies on palliative care, and David Holden's been working in our group as well through the out of hospital stream at SA Health to try and get some more clarity in that space as well. So just before Chris starts with his presentation as well, because he's got some really important updates in there for you, I thought I'd just mention about what's happening with the overseas travellers, because I think that's something of interest. I mean, we haven't heard a lot about it in the media, and I did say to the media team, I said, why is there nothing about all the great work that's been happening in this space. So that is going to happen now, which is fantastic. So hopefully we can get some thanks and praise for the South Australian Indian Medical Association, which has been led by Dr. Seshi Boda. They have undertaken now more than 165 GP consults for this group of passengers. So really we're talking about a number of people with quite significant comorbidities. And one of the reasons behind why we've seen people with so many medical issues is in fact because this was a charter flight, they didn't undergo the standard screening that would occur for passengers under commercial airline arrangements. So we've had a few medical issues that have then resulted in transfers to hospital and things like that. So that's just to give you a bit of context as to why we've seen and also just to mention these people had been in isolation for some of them more than 5 weeks prior to getting on the plane, so have not had medications for several weeks, have been really going through a very tough time. So from a mental health perspective, we've been able to ensure that they can have daily phone calls for mental health, can be referred for psychology if necessary. And then on top of that, we've had Seshi's team providing all those GP consults, and then they also get daily phone calls from the nursing staff or the Metropolitan Referral Unit, the MRU, to also check on their wellbeing and do a risk assessment. So every day they get a risk assessment undertaken, which goes through their symptoms, making sure they haven't developed any COVID symptoms. And none of those passengers have come back positive, which is fantastic. And we have re-swabbed a few who have had some upper respiratory tract symptoms that have developed, and we've not seen any COVID, which is just fantastic. So those passengers will come out of quarantine on Monday and Tuesday next week, as per the 14 days of required quarantine. But I just thought I'd give you a bit of an update to say how much an amazing job the South Australian Indian Medical Association with Seshu's team at Glenunga Medical have done for these patients. It's been a mammoth effort. So thank you so much. And I'll hand over to Chris now.
No worries. And hello, everybody. Not a huge lot. I'm just going to remind you first up about Health Pathways South Australia again, because I think whenever people still ask me about stuff that I've just talked about in the webinar, and it's all going to be on the Health Pathways SA. But there's been an addition to that, which is this thing called COVID-19 impact on clinical care. Because what's happening with COVID is there's a protocol for every sector of care now. So at the moment we've got it for maternity care or for endocrinology or dermatology, and each sector is coming out with clinical guidelines about COVID and how it impacts on care. So look, I'd suggest you click on that second little button to look up this sort of thing. We're trying to compile it all because obviously not everybody's going to be aware about all this work which is occurring in every known sector in response to COVID at the moment. So yeah, there's a second button in Health Pathways now, and as I said, there's an easy login now, so you can get in very straight into it. Just briefly about the telehealth items, it's been interesting because the most recent issue has been more about the fact that there's been a bit pushback from a bit of few of the pop-ups and things like that have come up, and also that the sort of there's been lack of access by some sectors, including sort of aged care. So there's actually been a bit of work, and I'm not trying to put my face there, more the fact that we've been doing a lot of media to try and start to isolate that off, because these pop-ups are just inappropriate. They're just total telehealth pop-ups, sometimes associated with pharmacy groups, and it's just inappropriate because they don't have a face-to-face arm. Look, we've come from the position where we've been wanting to open it up because there were doctors that were not able to provide face-to-face care because they were in, for example, in at-risk group, and also that there were new doctors coming on board who wanted to provide care, and also there were patients who needed care that couldn't find a doctor and couldn't see their usual doctor. So it did broaden out to the fact that you didn't have to see a doctor previously, and that for some people that didn't have to have face-to-face care. But I think all I could ask is, and I think hopefully the people on the webinar would understand that if we want this to continue, we just need to look after it and not be found to abuse it. I've got to say that the Department of Health, although they've been really good with this, are always going to be looking at how it's been used and if it's been appropriately used at the end of it. And the AMA is going to be extremely strong about it, keeping it, but there probably will be increasing restrictions later in the form of it will have to be provided by a usual doctor, for example, in the future. And maybe there will have to be the requirement that there is an ability to provide face-to-face care, which is in the intent at the moment. But, you know, obviously people are going around at the moment. Just briefly about e-prescribing again, because I'm just going to bring this up again because this is...
Well, we're still getting a lot of questions about this, Chris, so I'm very happy for you to talk about this.
So basically, the interim arrangements before we go for a full technological solution is to avoid the need for the original script to be sent to the pharmacy. You've got two options. The first is, under the National Special Arrangements, will only apply until 30th December for all scripts except SA or some S4s, including benzos. You can fax, email, or text the image of the signed script to the pharmacy, not to the patient, to the pharmacy, and then the doctor has to just keep the original signed script for 2 years. Now, I know that's a hassle, but hopefully they'll be only for the next month or so. The next thing is that there is an out, because obviously some of us have to send out S4 and S8 medication scripts. Now, for that one there, the best solution is to fax or e-fax the image only. You cannot text or email the image of the signed script to the pharmacy, and you have to name the dispensing pharmacy on the script. You just have to write, you don't have to write the full address or anything. I'm basically typing it in and typing the fax number, so you know the admin staff can just have got both of them and can send it straight off. You do not then need to even keep the script in that circumstance. So if you don't want to keep the script, that's the good option. Okay. So there are your two options. Briefly, just on COVID Safe app, which you've heard about, it's been interesting politics associated with that one, which was involved in late last week. But look, one thing to keep in mind, it's only a tool, it's not the panacea. And to be frank, primary care is going to be really important in the next phase. So understand it's only a tool, but it will be important, I think. But it's only one tool. The provisos with this is interesting because the proviso to this is that the patient can control their own privacy. They don't have to download it. They can even not want to download the final code to give the contract tracers the download the information. The patient can even put a pseudonym in there, a fake name. There's actually, you know, lots of protections. Now, what I would say to you with respect to that, being the chair of Ethics and Medical Legal Committee in the AMA, is that I know some doctors are still wary about this, about the privacy, but what I would say is it's not your privacy you're discussing, it's about the patient's privacy. And what I would say is just be careful about imposing your own views about privacy onto your patients. Your patients can make the decision as to whether they want to become a part of this. And just be aware of that, because that's something we tend to do a little bit of, and I have done that myself, but just be aware it's their privacy, they can make the decision. The second thing is that technological and privacy issue is the responsibility of government. The AMA was really strong about that it's not, that they have to ensure that's their responsibility. The final bit about getting it through, the AMA was very keen that there cannot be discrimination against those who do not participate in respect to this, and that has come out in one thing, in that you cannot coerce your staff to download it, and you cannot discriminate against patients who do not use it. So you can't actually discriminate and not see a patient who does not use COVID Safe at this stage. So that's really important to understand, that there are actually protections against that because of this discrimination aspect. So be aware about that. That's actually an aspect to care at the moment. That don't sound too, I'm not wanting to sound too glum about it, because I think this is actually going to be potentially a really important initiative in putting out spot fires later as a potential option. And it will help Louise's team, I think, won't it, potentially, hopefully. But hopefully we won't have any of that. So hopefully we won't have any cases to contact trace, but it would be nice to have it there. The final thing is that the AMA, and we've been working with Emily and other and some other groups with SA Health, and there's actually a lot more, I've got to say, a lot more appetite to progress a few things about improved hospital access to My Health Record. One of the problems that GPs have been frustrated about is that it took so that the hospitals didn't use it, but if you actually looked at the hospital version of My Health Record, it took 5 minutes to download My Health Record. That's why they weren't using it. It was actually a waste. So we're working now to get immediate access like we have at the moment. We're also looking for simultaneous point-to-point, that means fact secure messaging and point to space sending of all hospital documents, so that if they send out a discharge summary or they send out a result, that it goes both directly to the person, but it also gets to My Health Record, because you and I both all would know that sometimes they don't end up seeing the same doctor, or they'll see somebody else, or you may be the doctor at the other end and the result the discharge letter got sent to another doctor, and My Health Record's your backup position. The other exciting thing, which I'm just going to put out to you, is that we've been working to, one of the biggest, really just didn't make sense to me, is that the emergency departments, particularly at Royal Adelaide, which is the COVID hospital, were handing out discharge letters from the emergency department by paper, because there was no other way of sending it out, which is actually doesn't make sense, does it? If the patient dropped it, then that would be it. So we've been working with them to, for any place, emergency department that's linked to Sunrise or EPAS or whatever you like to call it, that there's immediate emailing of the discharge department discharge summaries to GPs by a new mechanism. Now, what we're looking for is for any of those who are any on the phone that are actually interested in this, to show an expression of interest, to maybe you could contact and just leave your name and email address with AMA South Australia. Or I've been speaking to Emily, and next week we'll put out a direct contact point for you to and advertise this. Because what it means is that if somebody's in an emergency department and they leave an emergency department, they'll automatically email you that result immediately, which is a lot better than a bit of paper being sent out, which may or may not get to you particularly from Royal Adelaide at the moment. So that's something to just watch out for, if you could, over the next little bit. But that's good news. So that's about it.
Thanks, Chris. A few questions for you come through. So we've had a few, and we have had a few come in as well through the email around keeping scripts for 2 years. So what are the requirements for keeping those scripts for 2 years? Can you just reprint them out and sign them at the 2-year mark from your medical software? Would that be acceptable if you're required to produce it for an audit? Or do you actually
I don't
have
think
to
you
keep
can, because it actually have a different number, but you can't. I mean,
Yes.
you actually need to keep the original signed copy
Yes.
for 2 years.
Yes, and so one of the things that I was speaking to Naomi Burgess about, the chief pharmacist, was in this space was around saving your paper copies as an electronic file is acceptable. So you can put them in on an electronic file as long as it's on the same basis for medical software. You have it security, it's backed up, and that is acceptable for storing it, because it comes under the legislation for storing of paper.
It would be a scanned copy of
Yes.
the original signed
Yes.
script.
Yeah, so that is an option, just to put, and then we have had a few emails about that as well from different people who are doing that. But
I don't think this is going to be the
Yeah.
radiology keeping the old X-rays thing, so I probably don't think we're going to be in that position. I mean, the old, oh God, X-rays.
And this is only till the end of September as well that we're doing this
right.
legislation in place. Hopefully we'll get e-scripts and all of those things, e-prescribing happening in a much quicker space. So that was one question. The other one was, what is Sunrise, Chris? Are you able to
Sunrise is
explain to people
EPAS. They renamed it EPAS because of political reasons, really. But anyway, it's EPAS. So it won't come out of Oasis. It won't come out of Oasis. So it's their current electronic product system.
And where does Sunrise work at, Chris? What hospitals?
So unfortunately, it's Royal Adelaide, it's Queen Elizabeth, it's not Flinders, I don't think. That's my recollection. Where else is it?
Port Augusta, Mount Gambier.
Yes. Thank you.
Yeah, it's not brilliant at the moment, but it's getting there. Yeah, just e-health, God, I'm just going to have patience.
It is complex, so we're looking at interim solutions for how we can bridge that until we get to different providers being able to offer that those electronic
But
options.
the Royal Adelaide was the one we needed it from, because that was just a disaster in terms of having only paper discharge summaries from Royal Adelaide. That just did not make sense.
Mm. And the question came through around scripts as well. Can you send the originals? Can you just send them to the pharmacy? Absolutely. You can absolutely send those still. And if you don't want the paper sitting in your clinic, then send it on to the pharmacy and they will retain it as per their requirements for PBS as well, auditing. So I'll just write that back as well. Now, Chris, when do you expect the advanced care directives can be uploaded to My Health Record by health providers?
Yeah, that's in play at the moment. I haven't got a confirmation about that, but we really want that. There's always been a bit of a resistance about that because of the potential, the really silly resistance, that it was actually the responsibility of the doctor to take on board everything that was in the advanced care directive, which was nuts, basically. It's just it's a benign, non-judgmental document, which is actually the patient's. So you're just doing it on their behalf. So it would just have to be a mechanism where you're doing it on their behalf. And the other flip side of that is actually interpreting an advanced care directive, and whether it's the latest one. That's always the big issue. Everybody always comes up and says, oh, what if it's not the latest one? The advanced care directive is clear in the fact that if you have an advanced care directive in front of you, which is you can act on it in good faith, and if there is a later one and you weren't to know it, it's not your problem. I mean, you just, as long as you act in good faith. Now, obviously, if somebody tells you there was another one, that's different. But if you've got the one in front of you and act in faith, that's as good as you can do. And God, that's all we can do, isn't it?
Mm. And this has been a huge burden on GPs, all of this additional paperwork. I know, Tom, you've said about SA pathology moving to there's that option for emailing as well that's going to exist. And it's brought up a lot of issues around encryption as well, and is emailing safe? So we've had a question around, is emailing of scripts safe as well? So what are your thoughts on that, Chris?
Look, I think unfortunately we've had to, in the current circumstances, accept a lower standard. It's not ideal, and it does come back to us to some degree. I mean, I know that when I was in the regional negotiations at telehealth for rural health, and I remember back then the bar was so high, it was actually ridiculous. Nobody was going to do it. So now we've actually gone way the other way, and certainly like SA Health, we're using Skype and stuff at the moment. I mean, like, we've gone the other way. I think we've got to find a happy medium. And all I can say with digital health is, can I say, I've been in this space, I've taken so much shit about digital health for so long, because I've actually been involved in it so long. And I'm going to say that because you can hear the frustration. But can I say that the thing about digital health is what's happened in the recent times has been wonderful, is that people have actually looked at what it can do, not what it can't do. And I think that's what's been really good about the whole exercise, is that people have actually reframed of where we are, that in fact that we actually are in quite an amazing country. We actually need to look at what can be done and actually work together to find the gaps to solve problems, rather than actually complaining all the time, because actually that doesn't help anything. So it's actually been pretty wonderful, and I've got to say a lot of great people have actually come up with great ideas. Even today, just listening to that, that's been fantastic. And I think that we have the opportunity to move forward here. And in fact, I've been speaking to the Minister, Chris McGowan, asking me what are the priorities, what lessons learned from here and the priorities. And I've got to tell you, the two have been general practice working with SA Health in a collaborative way. And Louise, Tom and I were in that first meeting with the GPs, and it was all rather tense and everybody was scared to death, and we know what it was like. But I've got to say the collaboration has been so good now, and I think there's been a greater mutual respect about how things move from here. It's been pretty wonderful, and I think we have a chance to do that. And the second has been digital health, about the fact that it's essential, and we actually need to look at the can-do aspect, not the cannot aspect. And I think and if we can all sort of buy in, and everybody's started to come on board now and understand the value of it and how much better it can make our world, but not just our world, it's our patients' world as well, potentially, as long as we don't abuse it and as long as we try to get that right balance of security and convenience.
And I mean, we've had a suggestion come through around emailing scripts with zipping files and passwords, not only to the pharmacy. And certainly you can do that. You can do encryption as well, but it is challenging, because then you're relying on the pharmacy, being able to do that, having the time to do that as well. And it's in a lot. And I've just put a guide in the Q&A as well that the RACGP has put out, because they have been working quite a lot in this space around email and general practice, around the risks associated with that and the consent requirements, and making sure that you're getting consent from the patient to do that. And then a lot of those privacy issues are actually not as big an issue. So a lot of it is around the consent process as well, and making sure that's documented and you're explaining that to the patient when you're sending files. In terms of other things, I mean, we've sort of covered a lot of things tonight. I guess really, are there any key points that, Louise or Tom or Jenny, Chris, that you wanted to talk about that you feel is important for GPs to know about during this time? And we did say this webinar was going to be about looking at this, how we sort of come out of this, or looking at the second wave for general practice. And Chris, you mentioned GPs are going to be vital in this, and often it's going to be the swabbing from the GPs as well, making sure they're swabbing those people who turn up with symptoms. But, Louise and Tom, what are your sort of thoughts on this in terms of the future and what we should be thinking about?
Well, I think in the intermediate term, we're still very much about ensuring there is no or very limited COVID in South Australia. So I would just emphasise the need to refer any of your patients who have any upper respiratory tract infections for swabs. We've had nearly a week with nothing, but we need to keep testing.
Mm.
And I think anyone who's being tested needs to be advised to be isolated whilst they wait their test. So that means, and explain that means what isolation means. It doesn't mean go and hang out with your family and, give them big hugs. It means you're sick. We're trying to stop that spread, and that's important. So, yeah, and I think that the other thing is, especially for healthcare workers, if you're sick, don't go to work, get tested.
Yes, and I think that is a really good point as well around if you are unwell, that you don't, if you have the swab for COVID and you think it's come back negative, I'll just head back into work. I think that is a really good point to emphasise. Don't head back to work. We shouldn't be clearing these patients and writing certificates saying you're okay to go to work, you've got a negative swab. Mm-hmm. If you're not well, you've got to think about what are you actually going to be passing on to those other workers in your workplace. And I know, Tom, you're changing now to just having the single COVID test as part of your key COVID testing centres at the RA and Flinders and Lyle McEwen, is that right?
Yes, that's right. So we've got a couple of different platforms. The one that most GPs are familiar with, we provide that full respiratory panel. So for the vast majority of your patients that go through the drive-throughs or you take the swabs and send in, you'll continue to get that full respiratory panel, including COVID. We are at the moment getting the best use out of all of our reagents by using the patients that present to COVID clinics, doing a COVID-only test. Now, we still can do the respiratory panel if it's clinically indicated, but essentially if you're presenting for a COVID clinic, you're being screened for COVID and that's the test you'll get.
And just on that, there are very low levels of respiratory viruses around at the moment, like flu is very low, everything's very low. The only thing that's of the respiratory pathogens that's just doing a little tiny kick up is pertussis. So if you've got someone who you think has, got pertussis, make sure you write that on your form.
Yeah, you'll get pertussis on the standard respiratory viral panel. Yep, that's part of the standard panel. Yeah, no,
it did, and then it got back on.
Rhinovirus is off. We've had to optimise to get the best use out of reagents, and that's why rhino is off, but pertussis is still very much there.
But it is quite encouraging that the levels of in the testing is really right down of not just COVID, it's other respiratory pathogens as well. And I think that's really that people are doing the social distancing. It's really quite encouraging.
I was just going to say, just to read, just for people on the phone for primary care, we had a meeting with Rob Krimful from the CSRO, the guy who runs a lot of the stuff that's going on at the moment, and it was about all things the scientific side of things last week. But it was really interesting. We were talking about the COVID Safe app, and we were talking about everything else that's going on at the moment. But what he said that for the next phase, primary care is actually going to be more important than the COVID Safe app in the next phase, because what's going to happen is, my suspicion is that, as we relax things, if there is anything out there, which hopefully in South Australia we don't, but if spot fires appear, there's going to be the need for the level of social distancing is going to be important. It's going to be patients not getting in the mood that they don't go out if they're unwell, but and the COVID Safe app may help with contact tracing, but it's actually the surveillance by primary care for anything that comes up is actually going to be really important in the next stage. And so I just will say to you that, this is the head of the CSRO technical side of things, clinical side of things, who's actually looking, biosecurity side of things, who's looking at it from the point of view of technology, but understanding that our role will be really important in the next phase.
Mm. And I think that's an excellent way to leave it, because that really is important, is about primary care. I am conscious there are other webinars on tonight as well, as people have reminded me via email and through the chat as well. So we will end it there. It's right on 7 o'clock. And thank you so much for listening tonight. And also I just want to mention thank you as well for those who watch later and who watch this through YouTube, put up through Adelaide PHN and through Crystal's team, because it is wonderful to see that you are keeping up to date, and we are seeing such fantastic results here in South Australia. And I feel that the GPs are doing such a wonderful job and are really helping with our cause and keeping our numbers down. So thank you so much and good evening.